may I invite Dr. Sabyasachi Pattanayak, sir. He is the Chairman, Scientific Committee of AIOC and Senior Consultant and Additional Director, Health Services, Government of Odisha, for his presentation. Thank you.
So, good morning.
That's it.
So, good morning, everybody. I thank Dr. Pranab Ranjan sir for giving me this scope of presenting before you. What we are discussing today in this morning is endophthalmitis, post-operative endophthalmitis. The very purpose of all this discussion is prophylaxis of endophthalmitis actually, how to avoid this condition to happen. Now, if this happens, then what to do? So, what we have discussed today, that all precautions, pre-operative sterilization procedure and others have to be taken very seriously in undertaking any intra-operative, before any intra-operative procedures in eye surgery. The second thing is installation of povidone iodine before the surgery and also a single drop after the surgery. So, this ensures 100% protection from endophthalmitis. But still, if it happens in spite of all this, then we have to promptly deal with the situation in order to save the sight of the patient. Now, at times what happens, we can see just a case of hypopyon also in post-operative period. So, we should not be panic in all situations. So, I am going to present two case scenarios. One is 53-year-old female, history of diabetes for 2 years, hypertensive, cataract surgery in the left eye undergone 2 years back, and presented with loss of vision in the right eye for the last 6 months as per her version, and he was advised for cataract surgery. So, this is the pre-operative finding of that patient, counting finger 4-meter vision, IOP normal, patent LPI, then mature cataract, fundus, no view in the right eye. So, what do we expect is there was an uneventful cataract surgery, as any ordinary day for any cataract surgeon. So, expectation was good vision, better than 6/9 in that eye, normal IOP, cornea clear, everything good. But what we see is this type of situation. In the first post-operative day, vision is 5/60, pressure slightly high, conjunctival congestion, limbus to limbus corneal edema, SK, hypopyon, AC reaction, severe, fibrinoid exudate over the IOL, but no cells in the antrovitreous space. Fundus relatively quiet, though not very clearly visible, no vitritis and retina is on. So, what to do? Now, we can think of a situation of TAS in those situations. So, what we did is hourly topical steroid, routine antibiotics, topical cycloplegics, oral steroid, patent bandage, and anti-glaucoma medications were also advised. Now, things improved within 7 days, visual acuity improved, and everything now appearing to be tending towards normal. And in day 15, we had a good vision and the outcome is good. So, it is not that in every situation we have to be panic in dealing those type of situations. So, we have to assess properly and deal with that. So, immediate post-op AC reactions within 24 hours with mild pain, watery discharge, no purulent discharge, relatively less conjunctival injection and lead involvement, limbus to limbus corneal edema, fibrinous exudates and hypopyon with relatively lesser AC reactions, normal IOP, no vitreous reaction, all these lead to TAS. So, but this is to be differentiated from infective endophthalmitis, which usually appears little later. Pain always present, lead edema is possible, conjunctival congestion, there is always, there is patchy corneal edema, variable pupil size, variable IOP, and temporary suppression of inflammation to steroid medication.
किस नाम से topic?
So, TAS can be because of many factors like bacterial endotoxins, intraocular irrigating solutions with abnormal pH,
ऊपर आ जाइए ना.
denuded ophthalmic surgical devices, visco, intraocular any medications, topical and ointments also, inadequate sterilization of surgical instruments and tubing, inadequate flushing of instruments between cases, preservatives and metallic precipitates. So, take-home message is not all AC reactions are endophthalmitis. Even a hypopyon can be sterile, just as in TAS. Acute severe inflammatory reaction of antechamber within 12 to 48 hours of surgery. Corneal edema extending from limbus to limbus. Dilated and irregular pupil, normal or slightly increased IOP. Presence of hypopyon and lack of bacterial and fungal growth all lead to the diagnosis of TAS. So, thank you very much.
Thank you, sir, for that presentation. So definitely, whenever there is a hypopyon, we have to actually think whether it's an endophthalmitis or TAS. So the most important differentiating features which sir had just mentioned is like the duration. Probably immediately within 24 hours, if they present, it could be TAS. But one thing is that if there is any doubt whether it is TAS or endophthalmitis, I think it is always better to err on the side of endophthalmitis and give intravitreal injections if there is any doubt.
In that case, I think BISCAN will help. You have to do a BISCAN to see.
To rule out vitreous involvement.
Because TAS primarily is a anterior segment
Yes.
inflammation, whereas endophthalmitis is a posterior segment. And there are so many vitreoretina people here. Just
But despite that, sometimes there is a doubt. For example, patient presents after 3 days with accelerated iritis. Okay, the vitreous may be clear. You give steroids. Okay, it recovers. And again, after few days or weeks, again if they develop, iritis. So these are the cases which are actually, creates a doubt in your mind whether it is, iritis or is it, going in for chronic fungal.
I think he has given a clue. If it is not improving within a week, definitely you can think in line of end of. But if it is improving within a week, I think it is more in favor of TAS.
Corneal infiltration also an important sign to exclude that. But still, we have to be very careful and think in mind that there can be endophthalmitis.
Yes.
We cannot rule out that, cannot be very much sure definitely that this is TAS and not endophthalmitis. So that has to be
very cautious, close monitoring.
Mind and close monitoring of the patient is very important to save the sight. Thank you, sir. Thank you very much.
I just wanted to ask them the role of ultrasonography in differentiating between TAS and endophthalmitis.
Yeah, it is of paramount importance, and you need to do it even if you suspect TAS. So you
yes, sir.
Mic.
आवाज नहीं आ रही. These mics are not working properly.
वहाँ पे.
It's work. Hello. Now it's work. Hello. Yes. So as far the TAS and endophthalmitis is concerned, the classical teaching is usually in the initial 3 days. If there is it is usually uveitis, not endophthalmitis. Just wanted to ask the chair and regarding that.
I think 3 days is a long time. Acute bacterial endophthalmitis, the presenting will be after 2 days.
Okay.
Most of the time, if a patient comes after 2 days of cataract surgery saying I'm having pain or redness, the first thing which will alert me, it is a acute bacterial endophthalmitis.
And associated signs and symptoms. They are like
absolutely
edema, severe pain, conjunctival circumferential congestion, and
even if the symptoms are not so alarming, even if there is congestion after 2 days which was not there before, it will warn me like it may be an endophthalmitis. So 2 days is a very crucial time, which I would say, because be very cautious for 2 days, because acute bacterial endophthalmitis will present, the acute bacterial endophthalmitis presents within 2 days of cataract surgery.
Let's listen to the question first. What's your question, sir?
No, the question was, usually the classical teaching is that whenever there is inflammation in the post-op period, if it is presented within 3 days, it's a usually because of uveitis, not endophthalmitis. It was very clear. And then thereafter, 8 to 9 days or within a 1 week, it may be more of related to infections or like that.
Yes, that is correct, because after postoperative, during discharge, the patient was all right, vision is good, there was no complaint, and subsequently developed some problem like pain and other things. That goes in favor of endophthalmitis. As usually you see in the next post-op, fast post-op day, there is reaction.
No, what 7 days you are saying it's a subacute endophthalmitis.
Okay.
Okay, so the organisms may be different. So 7 days is a very long time. And the classical acute fulminant, if you say, or acute bacterial endophthalmitis will present within 2 days.
Within 2 days.
Dr.
Yes.
Deepak, will you agree? I mean, what I have read in the literature, 3 to 5 days is the average for bacterial endophthalmitis, and within 24 hours is TAS. This is how
Within
you
24 hours it is TAS, but
TAS, yeah.
beyond that,
beyond that,
it should ring a bell that this could be acute bacterial.
Absolutely,
So 2 days is a
2 days. You
2 days. Yes.
Okay,
Yeah,
then.
actually,
Okay,
then.
you
Okay, then.
remember, Dr. Deepak, there is
Okay.
one
And that
case,
too,
and it presented 3 days, just after 3 days surgery, and it was a fulminant, we lead to the corneal infiltrates and everything.
Yeah.
But most of the time, it presents usually late for to us.
I think, Ajit, this is a very good message. If it is within 24 hours, 1 day, it goes in favor of TAS, and if it is between 1-2 days and beyond, that goes more in favor of the bacterial and endophthalmitis.
And that too in TAS, the symptoms improve with treatment.
Yes.
And in bacterial and infective endophthalmitis, it will deteriorate.
Definitely. Thank you.
So, can I just ask what should be the ideal post-operative review regime in these cases? So, we
Early-
cannot call them obviously on every day for post-operative review.
No, it should be called, they should be called every day.
No,
Ideal.
generally,
Yes,
post-operative cases, I'm asking. Not
No, no.
with, any case
If you
with
are seeing a reaction like this, you should call the patient every day or keep him admitted to see.
No,
every
because
day.
first day there could be TAS, second day there could be an acute endophthalmitis,
That's why you need to
fifth
see
day
every
also there could be an endophthalmitis. So what should be the usually how do you call these patients?
I mean, this. Should,
Yeah, so what is like first day you see, which is better, the immediate first day post-operatively or after 48 hours?
Definitely
The first review.
first day
First day
post-operative
they have to be
absolutely is.
seen.
First day is better.
First
Okay.
day, first week.
Yes, first day and first week, and in between, if they have any complaints, they should come, because first day it should be seen to see if there is any inflammation, what is the immediate post-operative status of the patient.
Yeah.
So 1 day after the surgery, patient has to be seen.
Oh, okay. Because sometimes when we do it on Saturday, we call them on Monday.
Madam, practically what I have been following for the last 15 years is that I see all patients after 6 hours and then next day.
Oh, okay. Thank you, sir.
Message is you have to see the
You are
patient.
telling after 2 days it may be a postoperative endophthalmitis. Then whether we can continue with steroids or stop steroids, and after it is tap only we can do.
Yes, steroids, topical steroids, it should be given to control the inflammation, but the dose has to be reduced. If you're giving hourly, it should be at least four times per day. But it should not be stopped because it's going to control some amount of inflammation also. The only thing is oral steroid should not be given until and unless a vitrectomy has been done. You understand? Yeah.
Can I ask one more question? So when you see these fungal postoperative cases, where do you think these infections are arising from?
Most.
Is it a sterilization protocol that's to blame, or is it the
just we
patient?
discussed that it can be exogenous or endogenous. If it is, if the
Yeah,
patient is-
exogenous. We are talking about the exogenous. Because post-operative, no? So mostly it will be exogenous only.
it can be through the wound most of the time.
It can be from the wound, it can be from the saline,
Yeah, I'm
the
asking.
source.
Saline.
It can be from the saline or from the viscoelastic also.
Viscoelastic